Zosteriform metastases from malignant melanoma. Zosteriform metastasis is a rare clinical distribution from spreading nucleus of various organs to the skin. Tumors most often arise from an internal or hematologic malignancy.
From melanocyte to melanoma. Melanocytes are cells that produce melanin, a brown-black pigment that determines the color of the skin, hair, and eyes in humans, and helps to guard against the damaging effects of the sun. In the skin, melanocytes are positioned at the epidermal-dermal junction, appearing as round cell bodies with long irregular extensions called dendrites. The formation of melanin occurs in the cell body, in an intracytoplasmic membrane-bound organelle called the melanosome. Next, the melanosome is transported by microtubules toward the surface of the melanocyte to a neighboring keratinocyte. Melanosomes are then released into the matrix of the cytoplasm in the keratinocyte and accumulate in the supranuclear region of the cytoplasm, thereby protecting the nuclei of dividing cells from the damaging effects of the sun. Several factors such as heritable predisposition and genetic mutations increase the risk of malignant melanoma. Ultraviolet UV radiation, such as that emitted by the sun, is directly absorbed by DNA and is a major risk factor for all types of skin cancer, including malignant melanoma. When UV radiation is absorbed by a double bond in a thymine base, the double bond opens, allowing the base to react with nearby molecules. If a UV-modified thymine base is adjacent to another thymine base on the same DNA strand, the two molecules can form a thymine dimer as a result of covalent bonding. The reaction most often involves the formation of two new bonds between neighboring bases, yielding a four-membered ring. The structural consequences of a UV-induced reaction include local distortions in the helix and a kinking in the DNA strand. If UV-related damage is not corrected by molecular repair mechanisms, DNA transcription and replication are blocked, and genetic information may be permanently mutated. Genetic mutations in melanocytes are associated with histologic changes along a continuum that may culminate in invasive malignancy. The transition from a normal melanocyte to metastatic melanoma may involve several histologic intermediates, including atypical dysplastic nevus of varying stages of severity, or melanoma in situ, and invasive melanoma. Indeed, melanomas diagnosed and treated during the radial growth phase have been shown to have an excellent prognosis. Currently, there is no cure for late-stage melanoma. As a result, early detection plays a critical role in reducing melanoma morbidity and mortality. New diagnostic tools to complement the visual examination of lesions, especially early-stage melanoma and borderline lesions, and those that lack the classic appearance of melanoma, could significantly enhance the detection process.
Applications in medicine. Case report. All men had long-standing red villous nodular lesions of his left leg and thigh. Examination disclosed many pigment nodules with Zosteriform distribution of the lower left limb with keratotic crust formation. Excision of the one nodule from his teeth with a 1 cm margin was performed, and histological cut smear studies showed a nodular tip of metastatic malignant melanoma without any dermal lymphatic involvement in peritoneal tissues. Amputation was not done because metastatic malignant melanoma cells were observed in ipsilateral lymph nodes.
Melanoma, the deadliest form of skin cancer. Approximately 70,000 new cases a year are diagnosed. Approximately 10% of those are fatal. The melanoma starts out as a normal-looking lesion in most cases, a mole or a nevus, which is like a little ink blot stain. And what the lesion will do is it will change shape, size, color, and sometimes begin to hurt. If you have any of these lesions and you notice any change in something that's been there for years and years and years, get it checked out immediately. The key to having a good outcome is early prevention and a thorough removal of all abnormal tissue.
Looks like a scrape almost.
ABCs of suspicious lesion is actually A, B, C, D, E. A is asymmetry. When we look at the lesion, we notice that it's not circular. It has borders that go in all different directions. C is the color. Millimeters. The larger lesions are the ones of greater concern. And E is evolving. It is evolving. So basically, you're going to feel a whole bunch of cold. I'm going to put a little bit of numbing medicine in there. Cold, cold, cold. Isn't that cold?
Yeah, it is.
That's very cold. Right behind there a little bit. A little cold. Okay, you're going to feel a little pinch. And you'll say, hey, what a mean guy. Say, ow, he's mean. And just a little burning as medicine goes in.
He's mean.
That's me.
You're the first one that took him up on that offer.
And this guy nice and numb. Good.
And I'm
For
going to
anesthesia, I use a little bit of 1% lidocaine with epinephrine. The epinephrine helps control the amount of bleeding by causing vasoconstriction. Okay, that's sharp, right? Poking with a stick. Sharp there, right?
A little bit, yeah.
Sharp there?
Yeah.
Okay. How about you feel that?
No.
Feel that at all?
No.
Feel that at all?
No.
How about there? Beautiful. That's how we love it. Okay. And you got the fix all right.
I have it ready to go.
Okay, so punch biopsy. This is a 3 mm punch. It's big enough to get a good-sized tissue sample. One of the main sources of misdiagnosis is getting an incomplete sample. If the lesion were less than 6 mm, I'd take out the entire thing. But since it's larger than 6 mm, what I want to do is leave most of the lesion intact so that if we have to go back, we can establish the depths of the borders. So basically, I'm going to go in the darkest, worst-looking part. And we want to go down to the level of subcutaneous fat.
Okay there, Clarence?
I'm fine.
Okay.
Okay. That light off my head. You don't feel anything, right?
No.
Okay. And I'm just working slowly down into lesion. Now, a common myth from days gone by is that by doing a partial lesion, if it were melanotic, that would go rampant. And that's been shown in studies to not be the case. So, okay, let's see what piece.
That's good.
Okay, that's down to the level of fat. And there's this guy. He's set aside. Something I could
That's a
stick.
long way to go, though. Yeah, if they win tonight, that's something, though.
I don't have a whole lot of high hopes for the fellas. Those darn Yankees are pretty good.
Yeah.
Okay, it's going to be good and sore later.
Oh, that's nice.
It'll just be like, one of those. Go up to the lab, and Pat's going to put a nice little dressing on that guy.
Will do.
And you're going to use a gauze and tape, no Band-Aids, okay? And you don't need any antibiotic ointment or anything. We're going to give you some betadine packets to clean it up with, and it'll go up to the lab, and we'll have a report beginning of the week, and then basically next week we're going to come back and excise the whole thing in the appropriate margins as dictated by.
Doesn't look any better than when I came in.
And everybody's a wise guy. All right, there you go. All right, we'll see you next week.
Okay, good.
Okay, so that's a fairly simple procedure that can mean life or death to a patient. Diagnosing a melanoma in time is crucial for a positive outcome. I'm going to send that specimen to the lab, and they're going to give us a report and tell us what kind of cells that we have. And I'll be able to determine exactly what margins to use when I do the total excision next week.
Chemotherapy was done but was without benefit. 4 months later, many more red-brown metastatic nodules appeared between 10. Lymphadenectomy was performed under histological findings, approved the diagnosis of metastatic melanoma. Tumor infiltration of the lymphatic vessels was observed in the lymph nodes in his groin. Pros and cons. Cons, no pros. Zosteriform cutaneous metastases arise from skin cancer, vascular tumors, hematologic malignancies. Malignant melanoma has a high tendency to metastasize to the skin. The pathophysiology background for zosteriform metastasis may be corner-like phenomenon as have been suggested by several descriptions of metastatic lesions in areas of recent herpes zoster infection.
Severe pain usually precedes the eruption of blistering rash or herpes zoster that is restricted to a dermatomal distribution as it is seen in these patients. More than one dermatome may be involved, but this should raise the possibility of an immunodeficiency state. A predilection for the 5th and 7th nerves. Ophthalmic herpes occur due to involvement of ophthalmic division of the trigeminal nerve, and Hutchinson sign stand for rash of the tip of the nose due to involvement of the nasal branch of the nasociliar nerve. This is a very important warning sign of involvement of the ophthalmic branch. This patient has blistering rash of the external ear due to involvement of geniculate ganglion with facial palsy, a condition that's called Ramsay-Hunt syndrome. Management should include acyclovir 800 milligrams 5 times per day per orally for 7 days.
Diseases: peritoneal mesothelioma. Malignant peritoneal mesothelioma is a rare type of cancer that occurs in the thin cells wall surrounding the abdominal cavity, known as the peritoneum. This thin membrane acts as lubricant within the abdominal cavity, so that surrounding organs and internal body structures may contract and expand within their normal body function. Incidence of peritoneal mesothelioma is quite rare and typically present in less than 5,000 individuals in the United States each year.
So there's another form of mesothelioma which is called peritoneal mesothelioma, and peritoneal mesothelioma is found strictly in the abdomen. It's usually found in the lining of the organs and something called the omentum. And the omentum in layman's terms is basically the apron of the stomach. It lays over the major organs. People function quite well without it, but it's where the mesothelioma tends to attack and to stay. I would compare it to sort of barnacles that you see on seaweed. It's like fine seeding along the whole omentum. Patients with peritoneal mesothelioma typically present to the doctor with abdominal pain, maybe a swelling. All of a sudden they can't button their pants or get their belts around them. They may have difficulty with bowel movements. And in more advanced cases, patients will have present with symptoms of nausea and vomiting, inability to have a bowel movement, and some abdominal pain.
Thanks.